Thanks, Hallie. That was great. And an interesting exploration of some of the tension around timeliness and certainty with this. I'm going to not hesitate to introduce our next speaker so that we can maximize some time for discussion. And it's a privilege to introduce Dr. Vincent Liu, who's a research scientist at Kaiser Division of Research and the Director of Systems Research Initiative, where many of us have read a lot of his work and have gotten to know him over time. And he's focused on using the electronic health record data, machine learning to identify innovative health systems approaches to prevent adverse outcomes, particularly in sepsis, but in hospitalized patients more broadly as well. He also has overseen the use of real-time predictive models to improve the care of over 4 million patients across the 21 hospital system in Northern California. So, Vinny, it's a pleasure to have you here and looking forward to your talk.
Thank you so much. Thank you for the invitation. Let's go ahead to the next slide. I have no conflicts of interest to disclose. Here are some of the funders, and I'd like to particularly thank the Gordon and Betty Moore Foundation for the invitation as well as the funding. Let's go ahead. So we've already heard sepsis diagnosis is challenging. It's challenging because there's no gold standard and the definitions change. It's challenging because the diagnosis needs to be made in a very compressed timeline. It's also challenging because sepsis diagnosis is measured by treatments. And we've already seen the high rate of discordance that we have at the clinical level, at the data level, really in establishing that we're doing a good job with diagnosis. I think we've heard some wonderful talks about how biomarkers and predictive analytics will drive our ability to improve diagnosis, as well as the targeted treatment of actionable subgroups. And of course, ongoing performance improvement programs and public education campaigns will continue to reinforce those needs. I get the opportunity to talk about how the health system can contribute to mitigating the impact of sepsis in our world and in our populations. And I'm going to focus on 4 major aspects, and I've tried to weave them together as a story and do that quickly within the time frame. Let's go to the next slide. The first thing I want to focus on is what's so-called the life cycle of sepsis, and to emphasize that nearly all of our research workflows and work has focused really on what I'll call the golden hours of treatment. Not that first hour, but maybe the first 6 hours, 3 to 6 hours that follow the presentation of a patient into our hospitals or our ED, which is marked by this black box. And if the y-axis is a measure of kind of the increasing infection severity as it becomes increasingly life-threatening and impacting different organs, we're really focused on quite a narrow part of what is a longer trajectory. Let's go to the next slide. Now, I think that there are almost certainly opportunities in the week leading up to sepsis, while an infection is progressing, in order to risk stratify and identify patients, even do primary sepsis prevention. And the problem is that we only see these patients in episodic opportunities or not at all. Sometimes they pop into the ED with no prior interactions. The question we've been asking is, are these patients seen frequently leading up to their sepsis hospitalization? Let's go to the next slide. And indeed, we have good population level evidence that they are. Among 46,000 patients that Hallie and I studied together in the KP and BA, we found that nearly 50% were seen by physicians in the week prior to sepsis. These data were confirmed through a CDC report where they did chart review from data from 10 states and I think about 1,200 patients. And they also confirmed that 61% had healthcare exposures in the week leading up to community-acquired sepsis. And when we've looked at symptom profiling, hundreds of thousands of sepsis and infection patients who end up in the hospital, we found that infectious symptoms peak, the acute onset of them peaks about 3 to 4 days before they show up in the hospital, although some of the high-risk symptoms like altered mental status peak closer to the actual hospitalization. The graph on the right shows that in the week leading up to sepsis, where day 0 on the right is the day the patient showed up in the hospital, day -7 is 7 days before, represent on the left panel in the bars, the percentage of encounters, outpatient encounters for diagnosed with an acute infection gradually rises, particularly about 3 days before, and the number of visits in the line also increases. And you can see that the outpatient use of antibiotics, both as an absolute value in the line as well as a proportion of encounters, is also rising. So there is evidence that there is a pre-sepsis signal, and we have a narrow but real window potentially to risk stratify these patients. Let's go to the next slide. Now, that perspective was from the perspective of people who ended up in the hospital. We actually need to flip the script and look at everybody in the population, because it may be that those patients who ultimately end up in the hospital, it represents a very small minority. And in the discussions we've talked already about predictive analytics, if you have a very low incidence rate, well, then you're going to have a massive false positive rate. And so what we did was we looked at all health system encounters, or really from three scenarios, which was the first at the time of hospital discharge, the second at an ED treat and release, and then a third being undifferentiated ambulatory visits. And so that was nearly 100 million encounters across our health system. And what we said was, from an undifferentiated, any one of these three scenarios, what's the likelihood that a patient's going to end up in the hospital in the next 7 days with either what we call suspected infection, which is the precursor to the sepsis 3 definition, or sepsis 3. And at baseline, we found about those numbers were about 2.5% for hospital discharge, 1.1% at ED treat and release, meaning 1 out of 100 of those patients would show up in the next 7 days, or as low as 0.3% for an outpatient visit. Here on the left panel, we show some of the timing of those broken into 6-hour increments over the week following their visit. On the top panel, we show ambulatory visit timing versus ED. And you can already see that there's differences and heterogeneity in the way that people are presenting to the hospital. It's often pretty close after an ambulatory visit at the top and then diminishes. In the ED discharge scenario, it peaks at about 24 hours. And following hospital discharge, it peaks about 4 days after their hospital discharge. And when we applied relatively simplistic chronic and acute severity illness indices, including sepsis scores, we actually could, pretty easily enrich that population and identify some high-risk strata. So there's data suggesting there's an opportunity, it may be narrow, and that with the right biomarkers and predictive analytics, we could potentially enrich this cohort. Now, we've also heard a lot about the challenges of antibiotic treatment. Let's go to the next slide. And antimicrobial resistance, and seeing the impact that that's going to have in 10 or 20 years as a major cause of death. The question is, many are thinking, well, we are already probably over-treating, and predictive models like this could result in even worse over-treatment. Data from the outpatient setting has strongly confirmed that as much as a third or even half of outpatient antibiotic prescriptions are likely to be inappropriate. And unfortunately, we see a large amount of differences and disparities, both by age, geographic conditions, as well as race, ethnicity. So the study on the left looked at geographic differences in antibiotic prescriptions in elderly patients, some of these tracked with socioeconomic bands. But you can see in the darker areas, those elderly patients were receiving nearly 1.5 antibiotic prescriptions per patient. So just kind of flooding communities with those antibiotics. On the right, this shows that there were racial ethnic disparities, and understanding these is going to be a critical piece to, understanding how we can effectively identify the right treatments and minimize the harms over the life cycle of sepsis. Which leads me to my second point, which is that a lot of our studies focus on understanding the benefits, but relatively few have looked at some of the harms associated with treatment. Let's go to the next slide. So sticking on the antibiotic theme, Hallie and I are working on a grant again across the KP and VA, where we're looking at some of the issues that she identified, which is what is the timing of antibiotics, what is the initiation, what is the discontinuation, and how have those played out over time as we put an increasing emphasis on the early treatment of sepsis. Now, clearly, if we are pushing, again, according to that theme of shoot, point, aim, we're going to alter that risk-benefit profile, and it's going to favor misdiagnosis. So among 4 million patients, we're looking at things like the spectrum score, which quantify the breadth of antibiotics here from broadest to narrowest, and then looking how those play out over hospitalization, how patients move between those, because there's a definite quantifiable amount of harm, and we need to balance that against the potential benefits. Now, I want to focus on 2 final thoughts and elements of where the health system really plays a critical role. Let's go to the next slide. There are some tremendous opportunities for designing experiments. And really, as some have said, including Dr. Angus, fusing clinical care and clinical research to maximize our learning opportunities, essentially using every patient that crosses through our doors as an opportunity to learn something more. So I give 2 examples here on the top. Investigators like Matt Semler and Wesley Self at Vanderbilt led two publications in the New England Journal that looked at embedded clinical trials of fluid management strategies that leverage what we think of as modest practice change, but they produce tremendous clinical insight. And I'll draw your attention to the figure on the right, which shows that what they did was change fluid management on a month-by-month basis between balanced crystalloids and saline. And that level of kind of embedded randomization produced great insights. And then below, Dr. Angus and an international team doing these kinds of embedded clinical trials that integrate a protocol, governance, EHR workflow changes, seamless data extraction, and then rigorous statistical designs to adapt the clinical arms. Let's go to the final slide. And the other question that we need to tackle is data interoperability. Millions of patients and data elements are being collected each day in the US, and yet they remain siloed. And so we now have the technical innovations in data interoperability available, but there's still some critical questions as to how we can bring these together and make them seamless so that we can learn dynamically, again, from every patient that crosses through our door. And this is a work that we're doing funded by the Moore Foundation between myself and Chris Seymour as the PIs, which is a collaboration between Kaiser and UPMC and eventually other health partners to do this. Let's go to the final slide. I know I'm running a little bit over. We know sepsis diagnosis is challenging. We're going to need biomarkers, predictive analytics, performance improvement, and public education. I believe health systems play a critical role in identifying the opportunities of improvement, both across the sepsis life cycle, understanding the real world risks and benefits of treatments, leveraging embedded research approaches, and ensuring data interoperability. And these should be designed and supported by health systems to ensure their value. Thank you very much.